Hello, Dr. Mark Contos with EyeTube Daily Coverage here at the Caribbean Eye Meeting in San Juan, Puerto Rico. And with me today is Dr. Robert Weinstock, and we're going to talk a little bit about the changing landscape of laser cataract surgery. Rob, let's talk a little bit about changing landscape of laser cataract surgery right now. What have you been finding?
Sure. Well, I gave a presentation here at the ACC Caribbean Eye Meeting on a little bit about that, the changing landscape. And you know, one thing to note is there's a huge body of literature that's growing. Michael Lawless did a phenomenal job recently of putting together a summation of the 60 or 70 articles in peer-reviewed journals now that are available about laser cataract surgery. The vast majority of these articles are showing that for almost all the parameters or treatments that this laser does, these lasers do, that it's as efficacious and as safe as manual cataract surgery. But there are some things coming out in the literature that are getting a lot of attention, one being the edge of the capsulotomy and whether or not the tensile strength of that capsulotomy when put under stress or tension is as good as if it's peeled manually by hand. And electron micrographs and different stress tests have been done, inconclusive. Anecdotally, you know, you hear about surgeons having a higher rate when they first start using this laser of anterior capsular rents, and I can speak to that because I noticed that, and it was something that maybe I changed my technique. But there's also the rapid improvement of the lasers that has transpired over the past 18 months and continues to happen, that a lot of the data that we're reading now in the journals may not be reflective of the software that we're using now that's much better.
Yeah, I think that's a really important point, because I think you and I both know, as we're using these lasers in their most, newest evolution, really, they're different than the lasers that we really started out with. I mean, in a lot of ways, and in the capsulotomy in particular, I think, as well as just the other functions of the laser and just ease of use even. There's big differences.
Yeah, it's really evolved rapidly, and I think it will too. I think that most of us that have experience with this laser have found that for dense cataracts or even medium dense cataracts, the fragmentation, especially like a cube or matrix style pattern, somebody who's got compromised endothelium, just most standard cases, breaking up that cataract is a clear advantageous than phacoemulsification energy and ultrasonic energy. Clear corneas, less endothelial damage, easier disassembly of the quadrants. The LRIs also, I mean, I don't think anybody really could argue that a manual LRI is as precise and as equally deep across the entire length or in the right location as the laser. But it keeps coming back to this capsulotomy. Now, for example, the LensX laser, a lot of that data that was being reported is based on prior to the SoftFit PI interface. That was a game-changing advancement for that laser.
Difference,
yeah, I mean, the capsulotomy, the laser time, the improved software. The LensR laser also, which I use, that laser's had like 4 or 5 software improvements, tweaks to the software to make it faster imaging, and now more customized software is being available for that laser to grade the nucleus, because on the Scheimpflug imaging you can actually see how dense the cataract is. It's very different than OCT. So now you're talking about ramping up the capabilities of the laser. And just last week, the Victus laser received clearance for a whole new wave of software that increases the speed, does a real live OCT during docking and treatment that's completely live the whole time, so you can see things happen, and also finds all the structures in the eye automatically, which the other lasers do already. So I'm just seeing a rapid advancement in the technology, and that's translating into quicker laser treatment times, faster docking and imaging, and less of these issues that were reported early on or that we saw early on, like corneal compression or capsular tags or loss of suction or some of the glitches that would happen with the software that would lead to incomplete treatments.
Yeah. Well, it sounds like really what's happening is what we would have expected to happen, and that is that the landscape is changing, and it's been changing from the very beginning. It'll continue to change, and the technology and the evolution of the technology involved with the laser is always going to be changing rapidly, it seems like. So we're probably going to be having this discussion again 6 months or a year from now, and we'll be talking about all kinds of new things that have gone on since we talked just now.
Yeah, I would say you're absolutely right. I mean, I think in another 6 to 12 months, we're going to have, for almost all the machines, a preoperative device that's part of the system. And that is going to directly, hopefully wirelessly, send preoperative treatments, including like a slit lamp photo that would automatically register on screen with the laser to eliminate cyclotorsion and align the eye. So that's going to eliminate another variable that we've always had,
Right.
eliminate marking of the eye. I think we're then going to have software that actually feeds overlay graphics into the operating room that allow us on a screen through the microscope or on a 3D screen see where the laser did its wounds or the outline of the capsular rhexis, because sometimes with the fragmentation it releases so much gas it's hard to see the edge of the rhexis. So if you have a little overlay that knows exactly where it was based on the laser treatment, it overlays while you're operating on and off. You can toggle that on and off. That's going to help guide us along with where the LRI is, along with intraoperative aberrometry. All of these technologies have to merge. It's not a matter of if they will. They have to for our own benefit and for the patient's benefit, because right now we're taking this machine and that machine and we're trying to like piecemeal them together and make them communicate together. But that is probably the next level that we're looking for, right, is this automation of the whole procedure refractively, because we need better outcomes. We know we need to keep chasing that.
Yeah. Well, it's exciting stuff. I appreciate you taking the time to visit with me about it.
Yeah, my pleasure.